Thank you very much for the kind introduction. I'm Dr. Edward from Hospital Duchess of Cairns, Sandakan. I'm currently a medical officer in the assistant medical officer for vascular surgery in Sandakan. So today my topic is when to refer a vascular surgeon. I think this is a relatively straightforward topic. So my talk will probably be going around how to assess the vascular status of those patients who presented with a chronic wound, and also what vascular services do we offer for those patients so that we can help in terms of chronic wound healing. So next. Let's recap what we have learned yesterday. So this is, I think this is a quite common diagram that shows the stages of wound healing. So there are basically 4 stages: hemostasis, inflammation, proliferation, and remodeling. So in a normal circumstances, in normal individuals, an acute wound, normally they heal within a period of 6 weeks to 8 weeks like that. So we allow time for up to 6 to 8 weeks for a wound to heal. And if any of this process is disrupted or delayed, then it will result in a chronic wound. So the definition of chronic wound is actually debatable. There are quite a lot of studies that shows maybe 6 weeks, 8 weeks. But I personally would say within 30 days, if a wound does not heal, we can consider it as a chronic wound. So interestingly to say, some of the chronic wounds, some of the patients with multiple comorbidities like diabetes, arterial venous disease and all that, actually whenever they have a wound, whenever they start to have a wound, the wound is actually destined to be a chronic wound initially. Since the starting of the wound, it's destined to be a chronic wound already because of the underlying pathophysiology. That's why what I'm going to talk about is how to deal with the underlying pathology before we treat the wound. Next. So here are some of the most common chronic wounds that we deal with from day-to-day activities: diabetic foot ulcer, pressure ulcer, but I will just mainly focus on the venous ulcer and arterial ulcer because there's a vascular aspect in this ulcer. Next. So here highlights the key feature between the venous and arterial ulcers. I think it's been highlighted by Dr. Ananda previously. So I think I will just focus on a few key points on how to identify arterial and venous ulcers. So the main difference, you can see the history part. Arterial and venous, they have a different history and also the pathophysiology. So in venous ulcers, the most common cause are deep vein thrombosis, chronic venous insufficiency, the venous incompetence. Meanwhile, in arterial, is actually most of the time you suggest of a history of peripheral arterial disease. If you ask further into the history, the patient will complain of intermittent claudication or rest pain. I'll go into detail into the vascular assessment later on. And key difference are the ages. For the venous ulcer is sloping, for arterial ulcers is punch out. And alright, let's go to the treatment. The treatment for venous ulcer is mainly compression. Just now Dr. also mentioned level 2 system, level 4 system and all that compression stocking. But there are surgical interventions for venous ulcers in patients with maybe long-standing chronic venous insufficiency that we can deal with. For arterial ulcers, mainly the main surgical intervention will be revascularization therapy. So let's move on to chronic venous insufficiency first. Next. There are a few surgical interventions we can offer. For example, the first one, stripping and ligation of the great saphenous vein. These are very commonly performed in older ages until recently. But we are slowly moving away from stripping and ligation of great saphenous vein because these procedures, the recent studies have shown that it carries a significantly increased post-op pain, first one, and also which can result in a very devastating quality of life for patients. And also, recent studies also suggest that after we strip and ligate the great surveillance vein, there are some form of neovascularization in these patients, which means the recurrence rate is actually increased back after this procedure. That's why we are slowly moving away from this procedure. There are other procedures as well, like varicose vein ligation, microfimpectomy, or previously known as step abortion fimpectomy. And the most popular one now is endovenous vein obliteration, which includes the radiofrequency ablation and also use of laser energy to close the deep venous system so that there won't be any reflux and the varicose vein or other dilated veins, superficial veins will be resolved. So once the superficial system, the reflux system the pressure is reduced, we hope that this may help in the healing of a venous ulcer. Next. So here are the examples of active venous ulcer on your left, pre and post endovenous laser ablation. This is a 6 months result. So patient present with typical venous ulcer located in the genital area, with lymphedema and also some form of hemocyanin deposits on the legs. These are very typical of a venous ulcer. So after the endovenous laser ablation and a proper wound care, then this is the result we can achieve in just nearly 6 months' time. So patient now, you see the skin integrity is good, and all the edema also reduced a bit. So this is the result that we want to achieve together with a proper wound care and addressing the underlying pathology in these patients. Next. So move on to vascular assessment of a chronic wound. Next. Why is it important? Because there's only one good reason. For proper wound healing, you need a good peripheral circulation. So as what I mentioned just now by Dr. Ananda, so this is what we're going to achieve. And interestingly, 50% of patients with diabetic foot ulcer now, we're seeing in clinics, 50% of them actually has underlying peripheral arterial disease. So it's our job as a frontliner to pick up all this, to address the issue so that we don't just rely on the wound care team to tackle the wound. So we have to make sure proper referral is done to vascular so that we can address the underlying issue, resolve the wound together with them. Next. For assessment part, of course, it consists of proper history taking and also physical examination. So I'll just briefly go through this. Patient with peripheral artery disease, mainly they present with claudication. This is very typical. Claudication means a reproducible pain, a muscular pain upon walking, and then typically the pain will reduce with rest. And also some of the patients with more moderate severe disease, they will tend to present with breast pain. Even when they're sleeping, when they slowly raise up their leg, they will feel pain. And also, we ask the risk factors, like diabetes, dyslipidemia, IHD, CVA, and smoking is highlighted here because smoking itself is an independent risk factor for peripheral arterial disease. If you ask me, most of the patients I see in clinics, 90% of them has a smoking history with PAD. So, cessation of smoking is a very important aspect in treating peripheral arterial disease. For physical examination-wise, there are three things: look, feel, and move. The look, when we look at the wound, when we assess the peripheral, the limbs of patients, we look at the color. Bluish or pale color, which would suggest of peripheral arterial disease. Look for trophic changes in diabetic foot. Look for the presence of gangrene. Maybe the wound is infected, the leg is infected, we don't know. And look for deformities. Look for Charcot stuff. We feel the warmth of the skin. If it's cold, such as a peripheral arterial disease, capillary refill time. Look for the wound surrounding tenderness, and we feel the pulses. This is important because the pulses at distal peripheries will tell us whether the circulation is good or not. It's very simple technique. Just feel the pulse, then you will know. So other special tests include Weber's test. If you want to know, you can Google that. Next, what we can do in clinic setting, we can perform an intrabrachial pressure index. This is also quite important. Interpretation-wise, for normal individuals, it's more than 0.9. If you measure it to be 0.5 to 0.9, there are some form of occlusions. So if we warrant a vascular outpatient clinic, we will because these kind of patients tend to be a chronic limb, so you can just refer as a vascular outpatient. But if you get the readings of less than 2.5, it indicates critical ischemia. At this point, actually, you need to have a urgent vascular consult, so you can just refer vascular at this point. For readings of more than 1.25, normally indicates patient of older age group when they have a calcified vessels, so the flow will be higher. Another thing is handheld Doppler ultrasound. I know most of the outpatient clinic and clinical setup would have this, but I think this is quite important in determining whether the vascular is compromised or not in this kind of patients, so it's important. For investigation-wise, what we normally do, the gold standard is actually angiography. Is performed by the vascular surgeon. You get a clear anatomy delineation before the operation. But what we can order our patient is actually arterial duplex ultrasound to assess the severity of location occlusion before we present the case to the vascular team. Okay, next. The surgical intervention for PAD, there are only two, either endovascular or open surgery. Endovascular is more preferred now, like in this modern age. So what we offer is angioplasty and stenting, like just now what Amanda has mentioned. Basically, we open back up the artery for revascularization. And the open surgery also is the same. We bypass the lesion. We normally will harvest a vein graft to bypass lesion, just as what you do on bypass surgery for the heart. So these two techniques, actually the outcome is almost similar, which means there's no significant difference between the outcome for patients undergoing endovascular or open surgery. But there are several concerns when we try to choose whether we use endovascular or open surgery. Because some of the patients, they have multiple comorbidities, they are very fragile, very ill. Normally, we won't prefer them to go undergo general anesthesia and go for open surgery. So, if the lesion is suitable for an endovascular approach, then we normally will prefer endovascular. But of course, there are times when the lesions in these vessels, there are multiple lesions, diffuse lesions across the whole limb, then maybe angioplasty or stenting will not work in these kind of cases. That's why we have to go back to open surgery also at the last. So it really depends on the patient factors. So, okay, next. So here is one example of arterial ulcer on the left. You see it's punch out defect. Then normally it's very painful for these patients. They will present with a very painful ulcer. They will come to you crying and say, "Oh, very painful ulcer." So this is what we do. We did the angioplasty for these patients. Then post-intervention, you can see a significant improvement in healing of the arterial ulcer wound. So this is what we have achieved for these patients. Next. Yeah, so I think this is my last slide, the take-home message. The first one, restoration of peripheral blood flow will improve the wound healing, definitely. So we always encourage to perform a vascular assessment when we are dealing with chronic wounds in our clinics. And also early recognition can potentially prevent or avoid an amputation. That's why I want to push you guys to just do the vascular assessment and refer if indicated. And the last one is a team effort. We can't do it alone. The wound care can't do it alone. The vascular service can't do it alone. So we have to work together to cure the chronic wound. Yeah, that concludes my slides. Next. These are my references. Yeah, thank you.